Hello, sir. Good morning. My name is Dr. Saha, one of the PACES candidate here today. I've been asked to examine your heart. Is that all right?
Yes.
So, sir, what I'm going to do, I'd like to have a good look first and then feel your heart and listen your heart. So, do you have any pain at this moment in your chest or in your heart at this moment?
No.
All right. Thank you very much, sir. So, during this procedure, if you have any of the pain or discomfort, just let me know. I'll stop at that moment.
No.
Yes, thank you very much. Hello, my dear doctor. Immediately after entering the room, you should have a good smile, my dear, with the good greetings to your patients. And saying them, good morning, good afternoon, sir. And introduce yourself. I am Dr. Saha, one of the PACES candidate here today. And immediately after that, you need to instruct to your patients, my dear. So greetings, introduction, and instructions. And instructions will be something like that. You need to tell, I've been asked to examine your heart. What I'm going to do, I'd like to have a good look first and feel and listen your heart. And my dear, the next three important points, that the pain, position, and posture, as I said. So the three important points is the greetings, introduction, instructions. Greeting, introduction, instructions, and then pain, position, and posture, my dear. Pain means the pain management. You can ask like that, do you have any of the pain, any parts of your body at this moment? And tell him and assure him and giving the good confidence, during this procedure, you'll not be having any of the discomfort state, my dear. So you need to tell the patients and you need to give the good assurance to them. So yes, the pain means you need to tell them, do you have any of the pain at any parts of your body at this moment? So during this procedure, if you feel any kinds of pain or discomfort, just let me know. I will stop at that moment, or I'll be very, very careful about on that particular part of the areas that I need to examine. In that way, you can get the good confidence from your patients, my dear, so that the patients will cooperate smoothly while you are doing the examinations in your real exams, my dear. And this is the pain position. Position means is the cardiovascular system needs the 45-degree angle. So as a candidate, you need to look at whether this is really the 45-degree angle is or not. So this is appropriately the 45-degree already placed. If the patient is lying flat, so you need to make the bed up, head and up, or if you cannot sometimes managing the bed, how to do that, just ask the examiner, sir, I'd like to make the patients in a 45-degree angle, and making the patients a 45-degree angle to examine the cardiovascular system. And last one is a posture, means the exposure, my dear. So the three P's that you can remember, that you need to tell to your patients, right, with the exposure. So yes, my dear, when you enter into the room having a good smile and good greetings to your patients, so this is immediately after looking at the patient's eyes, you can win the patient's heart altogether, a good smiling altogether. And also washing your hands and handshake with your patients and having a good confidence. And during this time and procedure altogether, this all includes altogether the introduction. Greetings and introduction, this procedure includes that wash your hands and also see the instructions. Because sometimes the instructions are helpful, my dear. You must look at the instructions. You see look at the instructions written here that the Station-03 cardiovascular system examine these young boys' cardiovascular system. So my dear, listen very carefully. If the instructions is something like that examine these young boys' cardiovascular system, or maybe you enter into the room that you have seen a young boy sitting onto the couch or onto the bed, and you need to examine the cardiovascular system. So you should think about some of the diseases that our young people are suffering. So my dear, listen very carefully in your PACES exam that you need to think about the young boy on the bed, so that you need to think about the diagnosis, my dear. The diagnoses are the congenital heart disease. And this congenital heart disease is really important that we divide it into the acyanotic congenital heart disease and cyanotic congenital heart disease. Acyanotic congenital heart disease, that you know about them, yes, my dear doctor, ASD, VSD, these are the two most common that you can think about, and third is a PDA. So ASD, VSD, PDA, and the cyanotic congenital heart disease, yes, my dear doctor, you know about the TOF, means the tetralogy of Fallot, and TGA means the transposition of the gate arteries, and TA for or TS for the tricuspid stenosis. But among them, that you need to think about these two diagnoses that you need to remember. For the acyanotic case of VSD and ASD, and cyanotic case, the TOF and TGA are the cases. But in your PACES exam, my dear, listen very carefully. The cases are usually given acyanotic congenital heart disease, and these are VSD and ASD. I used to speak the VSD, V for the baby, all right, you can remember. So yes, childhood cases, the VSD, but the ASD, A for adult, my dear. So yes, a bit of adolescent group of people, so that you can think of the adult means the ASD, and bit of child or children, or lower age group, so that you can think about the VSD. This is a bit of helpful tips and tricks, but not always helpful. But at least you can think about, yes, the diagnosis should be the VSD and ASD that you are dealing, my dear. So the summary talk, when you enter in the room, you have seen they examine these young boys, the cardiovascular system, the young boy, the diagnosis, VSD and ASD. Keep in your mind that VSD and ASD, that you need to start your examinations, my dear. So let me start how to do that. So yes, my dear doctor, you start with the introduction with the good greetings and the instructions written here. Then you come up with the instructions, and then pain, poser and positioning. And pain, positioning and poser. You have done everything together. Then you need to start your examination of the cardiovascular system. So my dear, how to do that? Definitely you need to expose him, and exposure needs just to tell him, sir, would you mind just put off your gown? Is that all right? Yes. Just sit forward for me, and just I'd like to open them. Yes, sir. Just lie back. Are you comfortable?
Yes.
Thank you very much. Yes, sir. So immediately after the exposure of your patients, my dear, you need to inspect the patient. Inspection, and then palpation, and then auscultation, my dear. So inspection will give us a good ideas of diagnostic approach, my dear, as we learn from the lectures, so that you can understand what will be the approaches, my dear. So in his case, a young boy having some of the cardiovascular disease, definitely you should think about the VSD and ASD, keep it in your mind, and then you need to inspect the patients. So let's start with the inspection. How to do that? A good candidate should go to the foot end and inspect the patient very gently. And what inspection that we are expecting? We are expecting the inspection, the most important part, the scar marks, my dear. So we need to be very vigilant to look for the scar marks. So let's see what the scar marks that we are expecting in his case. So now, let me show how to inspect with the patients. Sir, I'd like to have a good look first. So I'd like to, from the foot end bed first. Yes, sir. Can you raise your arms above the head like this, like this? Thank you very much. Thank you, sir. Yes. The best and the best and the best course ever you will experience in your whole life, my friend. So yes, my dear doctor, what you need to do, you need to go to the foot end bed And just tell your patients, can you raise your arms above the head and just look in the side, any of the scar mark, any thoracotomy scar is there or not, so that you can get the findings, my dear. Sometimes it happens in case of females. What you need to do, you need to tell to the female patients, madam, could you just lift up your breast for me so that you can see some of the inframammary scar marks sometimes hidden by the breast, my dear. So you need to tell them so that you can see them. And you have to be very vigilant to your patients to see the scars, my dear. So what are the scars that you have found in his case? So we found the scar marks a midline sternotomy scar with a 2 drainage scar, 2 small scars here. This is for the drainage tube postoperatively. So a midline sternotomy scar and the 2 small scar for the drain tube. So the main scar is the midline sternotomy scar. So it was the approach that we learned from the lectures, that whenever you found the midline sternotomy scar, that we need to see immediately after that any of the harvesting scar is present or not. And this is the harvesting scar, is the saphenous vein harvesting scar and maybe the radial artery harvesting scar. So let me show here, immediately after that you have seen the scar mark there in the midline sternotomy scar, then you need to look for any harvesting scar is present or not. Even though the young man, you need to look for it and just to confirm it, this is not the presence of the harvesting scar in the saphenous vein, and also that you need to see the radial artery altogether. He has no radial artery harvesting scar. Sternotomy scar. You can see the midline sternotomy scar with a small scar. So this is the midline sternotomy scar with the 2 small scar for the drainage tube. So whenever you have seen that the midline sternotomy scar, then you need to see the harvesting scar, the saphenous vein harvesting scar in the legs, and also the radial artery harvesting scar in the hands. There is no harvesting scar, no saphenous vein harvesting scar, and there is no saphenous vein harvesting scar here, and also there is no saphenous vein harvesting scar. Absolutely normal here, nothing is here. And whenever you need to see the edema, the peripheral leg edema, you need to put these hands a little bit more firm pressure over the medial malleolus, and you need to tell to your patients, right, do you have any pain in your legs?
No.
And after the pressure, then you need to feel, is there any dimple or not? So he has no dimples, so there are no leg edema. And he has no radial artery harvesting scar. Here is normal. And you see here, there is no radial artery harvesting scar. Can you do like this for me, sir? And just hold it here. And you need to see the clubbing is present or not in the level of the nail bed and the nail. And he has no clubbing at all. There is no clubbing, no clubbing, no clubbing, no clubbing. And you need to see the cyanosis as well, and the tips of the fingers to compare with own hand's color. That will be the black or blackish blue or bluish black color. So he has no cyanosis at all. So you see the tips of the fingers are normal color compared with your own hand's color. So the tips of the fingers are normal, not the bluish, not the cyanosed. He has some of the other things other than cardiovascular system. I'm just showing them so that you cannot confuse whether this is also related to the cardiovascular system or not. These are some of the skin disease, my dear. For a long period of time, you see some of the skin patches are there, and also very importantly, this is the space that you can see. Starting from the elbows, then up and up and up and up to the hands, you see you see. So, and also he has some of the skin patches here. You see here, you see here, and you see here. And also this is present in other different parts of your body. But the most important side of these one, we call it lichen striatus. Lichen striatus. So these lichen striatus is not related to his disease of cardiovascular system. I have just shown it so that you cannot confuse whether these are also findings of his any of the cardiovascular system or disease or not. This is a skin disease, lichen striatus. So yes, my dear doctor, immediately after look at him, the young boy having a midline sternotomy scar without any harvesting scar in the form of saphenous vein harvesting scar is absent. Radial artery harvesting scar is absent. So having a midline sternotomy scar in a young boy or young girl, immediately after look at him, such a young boy having a midline sternotomy scar with no harvesting scar in the form of saphenous vein harvesting scar and the radial artery harvesting scar. So what a candidate should think about the underlying etiology and the diagnosis. Yes, my dear, definitely the open heart surgery. But as I said, my dear, if you see the instructions of the young boy cardiovascular system, you should think about the ASD and VSD. Yes, my dear, these are the most important cases encountered in your exam. So you should think about ASD and VSD and definitely the ASD closure or the VSD closure. So yes, my dear, in such a young boy, you should think about the ASD and VSD closure, and maybe sometimes is a midline sternotomy scar without harvesting scar, the differential diagnosis you should think about, maybe the AVR or MBR or DVR. It has been the aortic valve replacement, mitral valve replacement or double valve replacement. Means I'm talking about the valve replacement, my dear. So but the first diagnosis should be the ASD or VSD, second one is a valve replacement. Think about it. So that you can start your examinations and the next stepwise fashion manner, so that make your diagnosis confirmed and immediately after that present your case, my dear. So what should be done immediately after the inspections? The first step that we should examine the peripheries, then to the center. So immediately after that you need to inspect from the hands examination first, my dear. So you need to see the hands first and you need to tell to your patient, sir, could you please do like this for me, do like this for me? Yes, just to get down yourself and see the clubbing that I'm looking for, the clubbing, and he has no clubbing at all. And immediately after that to look at the cyanosis, and he has no cyanosis at all. So no clubbing, no cyanosis. And along with the clubbing, as I said earlier, that you need to see any splinter hemorrhages in the nail bed, and he has no splinter hemorrhages. And immediately after that you have seen the clubbing, cyanosis, splinter hemorrhages, you need to tell him, can you turn around in your hands like this, and with your own hands, just to compare with all together, then you need to see the no genuination, and to see the palms of the fingers, to see any of the nodes. These are called the osseous nodes. Means in the turn round that you need to see the two important things, that is the osseous nodes and the genuination. So once again you start from the hands to see the clubbing, cyanosis and the splinter hemorrhages. Turn your hands, then you need to see the no osseous nodes, no genuination. And then you need to go up to see the pericardy and any of the purpura rashes, my dear. So once again that you start from the hands, clubbing, cyanosis and the splinter hemorrhages, my dear. And once again on the palms at the genuination and the osseous node and the pericardy and purpura. So aside it from the cyanosis, other than the cyanosis, the things are the clubbing, splinter hemorrhage, genuination and the osseous node and the pericardy and purpura, and the three other important findings, my dear, you need to keep in your mind. In the eyes with the ophthalmoscope, you need to see the rot spot. And the abdomen, then you need to palpate the spleen for the splenomegaly. And here, for the urine dipstick, to see the urine for sugar, urine for hematuria, my dear, means the RBC. So here's the rod spot, splenomegaly, hematuria, rod spot, splenomegaly, hematuria, rod spot, splenomegaly, and hematuria. These three, along with this clubbing, splinter hemorrhage, genuine lesion, and osseous node, and the pedicule and purpura, 2 to 2 is the 6, and these three are the 9 important features of the peripheral stigmata of infective endocarditis. You must comment on them. If any 2, 3, 4, 5 features that you are finding, so you should talk about, yes, these boy having no peripheral stigmata of infective endocarditis. So this is the peripheral stigmata of infective endocarditis, my dear, you need to comment on them. So yes, this boy having no clinical stigmata or peripheral stigmata of infective endocarditis. So yes, my dear, along with that, the peripheral stigmata of infective endocarditis, that you need to think about, as because I said it, there's a young boy, so you should think about the cyanotic. So you need to tell to your examiners at the presentation as well, these boy having no features of cyanosis and no peripheral stigmata of infective endocarditis, and cyanosis and clubbing altogether for the cyanotic congenital heart disease, as well as if the patient develop the ASD and VSD, the Eisenmenger syndrome, they will also develop the cyanosis and clubbing. So yes, my dear, commenting on the cyanosis and clubbing is really important, especially the young boy and young girl or the young group of peoples whenever you are examining, my dear. Yes, my dear doctor, immediately after you have seen the peripheral stigmata of infective endocarditis, along with the cyanosis and clubbing are absent, so you can think about the thought that you already did it earlier, that you diagnose the ASD and VSD. So yes, you can think about the ASD and VSD, still the diagnosis. So we need to start our examination from the pulse first. We need to comment on the pulse, then the blood pressure, then the JVP, then in the eyes, anemia and jaundice, and in the mouth, anemia, jaundice and gum hyperplasia, and then precordium examinations, my dear. And in the precordium, you need to comment on the apex beat, and then the features of the pulmonary hypertension, and immediately after that, the heart sounds, the first heart sound, second heart sound, and of course, the pulmonary component of the second heart sound altogether means the P2. You need to think about it. Might immediately after that, heart sounds, that you need to comment on the murmur, and after that, the lung heart failure, might mean the lungs crackles and the leg edema. That's the finish of these examinations here. So my dear, listen very carefully. We need to start such a young boy thinking that the diagnosis in ASD and VSD closer because he has got the scar mark, my dear. So we need to start the examine from his hands first. You need to tell, sir, I'd like to feel the pulse. I need to handshake and just flex and up. And you need to feel the pulse. And you need to count 15 seconds altogether. The best and the best and the best course ever you will experience in your whole life, my friend. And these total 15 seconds that I found that he has got the 15 bits. So 15 into 4 equal to, yes, the 60 or 672 bits per minute that you need to remember. So the rate usually in your exams will be in the sinus rate, my dear. So you don't need to worry about the rate. But you need to worry about the next important point, my dear. As I said, the approach should be started. You're looking for immediately after the rate, there's the rhythm, my dear. So you need to feel the rhythm separately. and you found this is regular. As I said, the first step is an irregular rhythm that we are looking for. So if the irregular rhythm, so you need to think about the atrial fibrillation. And now the irregular rhythm, as I say, the atrial fibrillation, the diagnosis should be the mitral stenosis with a mitral regurgitation. But in a young patient, that you need to think a little bit more, that if the irregular means atrial fibrillation and having a scar mark, there may be a possibility of atrial septal defect, because the atrial septal defect can lead to the left to right shunt and the atria will be dilated. Both atria can cause a dilated, that leads to the atrial fibrillation, means the atria becomes febrile, that leads to the atrial fibrillation. Yes, my dear, is important tips and tricks that we are adding now here. If you found the irregular pulse, that you can think about the ASD rather than a VSD, my dear. So yes, my dear, listen very carefully. We found the regular pulse, my dear. And immediately, if you found the regular, the next step that you need to feel that and asking yourself, is it low volume? No, this is not low volume. Next step, is it high volume? And this is not high volume. So you need to think about it. So he has got a normal rate, normal rhythm, and not low volume, not high volume, normal volume. The next step that we think about, and I said it earlier, and the next step that you need to think of, what is the lesion? Means that you think about is in the septum, my dear. Means that maybe the ASD or maybe the VSD. And ASD for the A for adult and VSD for the B for baby. So that you can think about it, my dear. So yes, in the pulse will direct you actually what's going on in the heart is a central part. So the pulse, once again, irregular pulse, atrial fibrillation, MS or without MR. But in a, yes, the young patients having a midline sternum scar, you should think about the maybe a possibility to the VSD-Closure. But if the rhythm is regular, so you can think about the, yes, maybe the VSD-Closure. Another clue that you can think about it. And the next step, yes, my dear, you are looking for the low volume, so this is not a low volume. If it would be the low volume that you can think about, yes, the severe aortic stenosis. If it is high volume, then you can think about the severe aortic regurgitation. Because if not low volume, not high volume, then the next step you should think about, yes, is it adult? So the ASD, if it is a baby, for the BSD, so that you can remember, my dear. So a bit of idea that we have found that these young boys may have the VSD-Closure, a possibility diagnosis, because the pulse is regular rather than irregular atrial fibrillation. Immediately after the pulse examination, my dear, the blood pressure, you need to ask to your examiner, sir, I'd like to know the blood pressure of this young boy. Or you can say in another ways, sir, I'd like to measure the blood pressure of this young boy. So you need to, yes, tell the examiner. Sometimes the examiner is saying that, yes, he is 120/80. So we can get the normal blood pressure, and also you need to immediately count the pulse pressure altogether. But in his case, you don't need to worry about it. Next, you need to go up, my dear. The JVP means the jugular venous pressure. Yes, my dear, raised JVP is an important feature. As I said, the right heart failure. So R for the raised JVP, H for hepatomegaly, and F for foot edema, so that you can assess the right heart failure. And in his case, the right heart failure is really important. So once again, we need to examine the right heart failure. The features, my dear, is the raised JVP. So you need to tell him, could you please turn your head on the left side? Yes, sir, just a little bit, thank you. And you need to be very vigilant to look at here to see the raised JVPs. So he has no raised JVP, but you can feel here no raised JVP. And you need to tell him, sir, do you have any pain in your tummy at this moment?
No.
Thank you, sir. And you just give a good pressure here and to see the JVP waveforms. What we are expecting in the JVP, my dear? We are expecting, I said it, a big waves in the neck. You should think about the diagnosis, the BTR, versus CAR means the car. VTR means the V waves, giant V waves, big waves for the tricuspid regurgitation versus the Corrigan sign or carotid pulsation or carotid dancing of aortic regurgitation. That's why I call the VTR versus the car, my dear. So here there is no VTR, so he has no raised JVP, and also the PACE means the pulmonary hypertension, which is complicated by the right heart failure, but he has no features of raised JVP. And he has no tender hepatomegaly as I have seen, and we'll see whether he has the leg edema or not. Immediately after the JVP, my dear doctor, you need to look at the eyes for the anemia jaundice, then the mouth for the anemia jaundice and gamma hyperplasia. Just let's see how to do that. So sir, could you just look up for me and look down and stick your tongue out for me and tongue up. Yes, we are looking for the anemia jaundice, anemia jaundice. And can you show me your gum, sir? Show me your gum. And to see the gum hyperplasia. That's it. So he has no anemia, no jaundice, and no gum hyperplasia. Immediately after the peripheral examination that you have done by the pulse, blood pressure, JVP, anemia jaundice, and gum hyperplasia in the mouth, then you need to see the apex beat, my dear, means the precordium examination, the central examination. The precordium examination starts with the apex beat, my dear. The most important that you need to comment on them, you need to feel and you need to see. So let's see the apex beat here. So you're looking for any visible apex beat. So you just put your hands here. And I'm finding the apex beat is here. So this is very important, just below the nipple and just medial to the midclavicular line. So you can also count, this is the second, this is the third, this is the fourth, and this is the fifth, left fifth interosseous space. And this is in position, apex beat, normal character as well. Knowing these facts of the apex beat finding is really important. Why I'm saying? Because the apex beat is thrusting and also the displaced that you're looking for. Because the ventricular septal defect will make the left ventricle dilated, and that leads to the thrusting and displaced apex beat. As because in the findings that the young boy having the pulse normal and having a midline sternum scar, that we can make our diagnosis, the VSD-Closure is a diagnosis. And now we are putting our hands, we are looking for the ventricular septal defect that leads to the thrusting apex beat or not. And the displaced and thrusting apex beat or not. So we found the apex beat is in the normal position. Immediately after the apex beat examinations, what we need to do, we need to examine the PHT findings, my dear. So yes, immediately after the apex beat that he examined, which is in the left fifth interosseous space in the normal position with the normal character, we need to examine the PHT, means the pulmonary hypertension. P for the P2, H for the heave or the left parasternal heave, and T for tricuspid regurgitations. So yes, my dear, we need to examine the PHT altogether. So yes, let's do it, the PHT. P for palpable P2. So just feel the palpable P2 first. And he has no palpable P2. Immediately after that, you need to see the H for heave, means the left parasternal heave. So he has no left parasternal heave. If the heave would be present, so the hands will be the lifting altogether. So he has no left parasternal heave. And the tricuspid regurgitation, so this is the left fourth interosseous space. And this is the functional tear that we said. If the tricuspid regurgitation would be there, So definitely the VTR means the V giant V waves of the tricuspid regurgitation would be there. As because he has no VTR means the giant V waves, so we shouldn't think about too much vigilantly. Just put your hands here. That's it. So the PHT, but might listen very carefully. One of the important tips and tricks, you need to auscultate the P2 whether it's really loud or not, because it's the most initial finding. That's why the PHT that I put it here. So the P for P2, H for left personal heave, and T for tricuspid regurgitation. So we need to be very, very vigilant. In his case, in a young boy case, of course, thinking about the VSD-Closure, so we need to think about the pulmonary hypertension features are present or not. Immediately after the PHT, we need to comment on the heart sounds, my dear. And as we learned, the heart sounds means that we are looking for the soft A2 for the severe aortic stenosis that is directed by the pulse, low volume pulse. But as because you have found that you have no low volume pulse, so you shouldn't worry about the soft A2. And I say the soft A2 and loud S1. So loud S1 for the mitral stenosis, just keep in your mind in the heart sounds. Even then you are not expecting, but you need to examine the first sound for the left fifth intercostal space, and once again the loud A2 or soft A2 in the right second intercostal space. But immediately after that, the heart sounds is really important. As I said, the P2, my dear, means we are expecting the loud P2 rather than any other abnormality. So loud S1, soft A2, and loud P2. So let's do it with the stethoscope, my dear. And just tell your patients, right, I like to listen to your heart. And put the stethoscope onto the left fifth intercostal space. What we're looking for? Loud S1. So he has no loud S1. We're looking for the soft A2. So he has no soft A2. And we should be very vigilant in his case, rather than soft A2, loud S1, the P2. Loud P2 we are looking for. So put the stethoscope here. He has no loud P2, but he has another findings, a wide splitting of the second R sound. And this is A2 and P2, there is a gap. Now the question, why this is the gap? This is the gap in between the A2 and P2. I say the A for NT means the before, then there is the P for post, means the after. Closure that happens in our physiological body and the hemodynamics of the heart, my dear. So A2 means the aortic valve closed before the P means the pulmonary valve, means the post. So yes, my dear doctor, whenever the VSD means the left to right shunt, so the left-sided blood, more and more extra blood on the right side, and that delays the pulmonary valve to close, so that leads to the wide splitting of the second R sound. So the A2, P2, so you have to be very vigilant to listen onto the left second intercostal space. The best and the best course ever you will experience in your whole life, my friend. To listen the A2 and P2 gap, my dear doctor. Now the question is, having a midline stenotic scar, already the VSD closure has been done, so why you are getting these findings? The gap in between the A2 and B2, why? The answer is, there is the residual VSD. What I say? The residual VSD, my dear doctor. And now that we need to immediately after that keep in your mind the residual VSD, the possibility, the wide split of the second heart sound. So what do you need to do? You need to accentuate and also to see any of the changes with the respiration, the splitting is going on or not. So you need to tell the patients to take a deep breath in and hold it there. Take a deep breath in and hold it there. Now take a deep breath out and hold it there. So yes, my dear doctor, this is very important. You are getting always a splitting is there. So A2 followed by P2. So you can think about the residual VSD is a likely diagnosis. Immediately after the heart sounds, the murmur that you need to very vigilant, and that you are expecting, as you say, the residual VSD. So you need to put the stethoscope to get the findings of the VSD murmur. And the VSD murmur is a pansystolic murmur, best heart, the left lower sternal Jones. But you need to screen fast for the left fifth first, then the left fourth, then the left third, then the left second, and then the right second, my dear. So what I say, the left fifth. So let's start from the left fifth intercostal space. A screening should be done. So when you start the auscultation from the left fifth, left fourth, left third, left second, and the right second, and also an infraclavicular space that you need to screen. This is called the screening for the murmur. And during this screening that you will get some of the abnormal sounds, and I found an abnormal sound. There is a pansystolic murmur in the left fifth intercostal space. And this is the space that I found a pansystolic murmur. This is the pansystolic murmur. And you need to tell him to quantify whether this is the left fourth intercostal space. If you're getting a pansystolic murmur, the differential diagnosis, the tricuspid regurgitation. So you need to tell him, take a deep breath in and hold it there, and take a deep breath out and hold it there. Because whenever we take a deep breath in, so we are getting the right-sided heart gets the more and more blood. And when it gets breaths out, we are giving the blood to the left side. Just feel it so that you can remember, my dear. So we are getting the more and more blood on the right side of the heart. We are giving the more and more blood on the left side. So my dear, listen very carefully. Whenever we take a deep breath in, so definitely the right-sided murmur that you can get the more and more. And when after breath holding, that you'll get the left-sided murmur more and more. As because the tricuspid regurgitation, the right-sided murmur, so we'll get the more and more with deep inspiration, my dear. So let me see that one once again. Turn your head on the left side. Now take a deep breath in and hold it there. Now out. And hold it now. Now take a deep breath in and hold it there. Now out. Hold it there. Thank you. So what we are getting, my dear? We are getting the pansystolic murmur which is not tensed with the inspiration and expiration, because in the septum, so there will be no tense. So we are getting a pansystolic murmur with no radiation on the left fourth intercostal space, and that no changes with the respiration, with the inspiration and expiration. Yes, my dear doctor, immediately after that you found that the pansystolic murmur best start on the left fourth intercostal space with no radiation and also with no changes with the respiration, both inspiration and expiration. The VSD is a likely diagnosis, means the ventricular septal defect. And having a midline sternum scar with a pansystolic murmur consistent with the VSD, so yes, we can make the diagnosis of residual VSD. My dear, listen very carefully. Diagnosing the residual VSD not only means that you finish the case, my dear. You need to always auscultate, and the spatial maneuvers should be done for the mitral stenosis as well as the aortic stenosis as well as the aortic regurgitation, and also to screen the whole heart on the precordium to get any other abnormal sounds. Because, my dear, listen very carefully, the VSD is a congenital heart disease, and this congenital heart disease can be associated with a long list of other congenital abnormalities. So that's why you need to screen them rather than knowing the facts of what are the associations. You will know them, I'll give you the tips and tricks how to know them, but yes, you need to just to screen other associated murmur or associated abnormalities are found or not, my dear. As because you started with the auscultation with each and every spaces on the precordium, and you found the pansystolic murmur consistent with the VSD, and immediately after that you need to screen for the MS, for the mitral stenosis maneuver, aortic stenosis maneuver, aortic regurgitation maneuver. Let's do it and let's see is there any other findings he is having or not. So let's do it for the mitral stenosis maneuver. As we already done with the mitral stenosis, with the bell of the stethoscope, with the left lateral space, with the breath holding after expiration. Sir, can you just turn around on the left side? Yes, excellent. And put this stethoscope, yes, with the bell, and always put your hands whenever you are assessing the murmur, and put the stethoscope is here. Take a deep breath in and out, hold it there. So yes, he doesn't have any of the mid-diastolic murmur. Immediately after that, tell him just lie back for me, and can you just sit forward for me, sir? Sit forward like this, sit forward, yes. And put the stethoscope with the diaphragm on the left third intercostal space to listen the aortic regurgitation, and tell him just, could you please take a deep breath in and out, hold it there. And once again put the stethoscope to the right second intercostal space for the aortic stenosis. Once again take a deep breath in and out and hold it there. So there is no aortic regurgitation on the left third intercostal space and no aortic stenosis murmur on the right second intercostal space. Immediately after that the patient is sitting forward, you need to see onto the back for the lungs crackles, my dear, for the left heart failure features. Just put the stethoscope onto the back, take a deep breath in and out. Once again, sir, Take a deep breath in and out. So we are looking for the left heart failure features, means the L for the lungs crackles in the left heart failure features. And immediately after the left heart failure features, the right heart failure, as I said, the raised JBB, H for hepatomegaly, tender pulsatile hepatomegaly, and F for foot edema. So you need to see the foot edema and tell him, sir, do you have any pain at this moment in your legs? Any painful? Is it painful? No. Thank you. And you need to hold it here and you need to feel, is there any dimple? Is there any pitting edema is or not? And immediately after that, you finish your examinations. You need to see the some bedside surroundings. Sometimes the bedside surroundings will give you the idea. Sometimes the yellow book will be there because the yellow book is nothing but the warfarin. The patient is on warfarin. Evidences, my dear. As because I have seen there is no yellow book at the bedside, so we can say this boy is not on warfarin. Immediately after that you examine, you finished. You need to give a good thanks to the patient and having a good smile, because giving a good smile and good thanks and saying some of the excellent word, fantastic the word that you can say, that makes the environment to the excellent and fantastic, my dear, so that you can, yes, give the viva with your examiners, my dear, and impress them very well. So what you need to do, you need to give a good thanks to the patient. Sir, thank you very much. You have done excellent. You are fantastic. And saying this good smile and good attitudes to your patients, and the patients will feel really good and comfortable. And of course, the examiners will feel that the word they used, that the fantastic, and he has done excellent. So it will make the environment in a positive environment, my dear. Immediately after that, you give the good thanks. You need to give the clothes back to the patients, my dear, and tell him, sir, thank you very much, and just tell him, just wear his dress. Yes, sir. And during this procedure, you tell him once again, sir, you have done excellent for me. You have done the great job. Excellent, my dear. And you just lie back him. And once again, you finished your examination. You need to wash your hands, my dear. So washing hands is really important because this is one of the most important protocol, the infection protocol, my dear, control protocol. So infection control protocol is very strict enough. It is said that if you don't do that, there will be a negative marking. Immediately after that, you finish your hand wash, you prepare yourself in the meantime and formulate yourself your diagnosis and whatever that you are going to present your examiners, my dear. You need to take the stethoscope in your hands because the presentation says that you don't need to wear like this or like this. Yes, my dear, you need to hold the stethoscope in your hands and then come forward to your examiners and present your case. So my dear, listen very carefully. The presentation is one of the most important integral part to get the high marks, my dear, even the 20 out of 20 to impress the examiners. If you present very well and you formulate it beforehand, before presenting your case, or you practiced many times that the way that I'm preparing yourself, my dear, you will do the best in your exam, my dear. Just listen very carefully. What are the things that you must include in your presentation? Keeping them in mind, that will be the best presentations, my dear. So let me start by the presentation that will include the number one in his case is a residual VSD, the first one. What I said, the residual ventricular septal defect. Means he has got the ventricular septal defect, but we need to talk the residual VSD. Yes, my dear. And the second important point, that the pulmonary hypertension, means the VSD is not complicated by the pulmonary hypertension. And the third important component, the VSD is not complicated by Eisenmenger syndrome as well. And also the absence of the right heart failure. And the fourth important point, the VSD is not also complicated by the left heart failure. And next, the VSD is not complicated by the infective endocarditis, the fifth important point, my dear. And also, any evidences of the medication he's on, like the warfarin, any yellow book at the bedside. you need to tell them, and you need to formulate these speeches altogether. The 6 important points that you need to include in your presentations. So let me show how to do that. And I'm now presenting this case, this young boy. You should speak the word that the young boy, not the patient, my dear. I used to speak the word of this patient, my dear. One of the most important tips and tricks that when you present your case, my dear, you need to look at the 2 eyes of the leading examiners and also another 2 eyes of another non-leading examiners. Because one examiner will ask you every question, so the people used to do only looking at the 2 eyes of the dominant examiner who is asking you questions, my dear. But this is the wrong idea. The tips and tricks, you always involve both of the eyes of both of the examiners and presenting in a rhythmic fashion and impress the examiner, my dear. How to do that? Just look at me, my dear. Immediately after you examine, you finished, and give the good thanks and giving the clothes back, always, my dear, wash your hands, and then after that you need to tell, sir, I'd like to finish my cardiovascular system examination to see the observation chart, and that includes the pulse, temperature, respiratory rate and blood pressure and oxygen saturation. And I'd like to see and do the urine dipstick to see the sugar, protein, RBC nitrites. So my clinical diagnosis of this young boy is residual ventricular septal defect, evidenced by midline sternotomy scar without any harvesting scar in the form of saphenous vein harvesting scar, without any radial artery harvesting scar. So yes, this young boy has got the residual VSD, that evidenced by midline sternotomy scar without any harvesting scar, and also evidenced by there is a pansystolic murmur best high in the left fourth intercostal space with no changes with the respiration, with no radiation. And this VSD is not associated with any other abnormal murmurs or any other abnormal pathologies in the heart. And the most importantly, this VSD is not complicated by pulmonary hypertension, as evidenced by absence of the loud P2 and absence of left parasternal heave and absence of tricuspid regurgitation, as evidenced by absence of pansystolic murmur and absence of the giant VOS in the tricuspid regurgitation. And also this boy is not complicated by the right heart failure, evidenced by the absence of the raised JVP and hepatomegaly and the foot edema. And also this young boy, the ventricular septal defect is not also complicated by the left heart failure, evidenced by the absence of the lungs crackles bilaterally. And also this young boy ventricular septal defect is also not complicated by infective endocarditis because of absence of peripheral stigmata of infective endocarditis, absence of clubbing, splinter hemorrhages, genuine lesions, osseous node. And also to see the more and more evidences of peripheral stigmata infective endocarditis, I need to see the ophthalmoscope to see the Roth spot and to examine the abdomen to see the splenomegaly and to do the urine dipstick to see the hematuria. But I have seen there is no clinical evidence of infective endocarditis, peripheral stigmata. And also I have seen there is no bedside yellow book. It has mean this young boy is not on warfarin. And also I have seen no skin, any of the changes, any of the bruises on the skin, so that I can say that this boy is on warfarin. This boy is not on warfarin because the absence of these findings, the absence of yellow book, absence of any other skin bruises. The best and the best and the best course ever you will experience in your whole life, my friend. So putting all them together, my clinical diagnosis of this young boy is a residual VSD, not complicated by pulmonary hypertension, not complicated by the right heart failure, without left heart failure, without peripheral stigmatoinfective endocarditis, and he is not on warfarin. I would like to confirm my diagnosis by requesting a color Doppler echocardiography. So examiner may ask you, what will be the management of this young boy at this moment? As because you said it, that he has got the residual ventricular septal defect even after correction of the ventricular septal defect, without any evidence of the pulmonary hypertension, Eisenmenger syndrome, without right heart failure, without left heart failure, without peripheral stigmatoinfective endocarditis, and he is not on warfarin. So he has got the ventricular septal defect, which is hemodynamically insignificant. And the word is really important saying that, and he's still having the left to right shunt. And in your presentation also you can add this word, he has got the ventricular septal defect, left to right shunt. Saying them, giving a good impressions to the examiners altogether, my dear. Now listen very carefully, it's very important talks, that the ventricular septal defects are the 4 categories, my dear. The most common variety, we call it the perimembranous type. And sometimes the examiner is asking this question, what are the varieties of VSD? The VSD are classified into 4 types, perimembranous, muscular. Perimembranous is the most common, and muscular is the second one. And third and fourth, just to remember, the posterior variety and the infundibular variety. So that you can remember the perimembranous muscular, posterior, infundibular. So that you can remember perimembranous muscular, posterior, infundibular. So the perimembranous variety is the most common, which is in the membranous part of the septum there is a defect, usually just below the aortic valve. So this is called the perimembranous ventricular septal defect. Examiner is asking sometimes the question, what are the causes of ventricular septal defect? The ventricular septal defect is caused by congenital, the most common, the congenital, and the second most is the acquired. Congenital is the most common, the VSDs. Acquired causes are a less bit uncommon. So the acquired causes are the most common. You can think about the post-myocardial infarction. It is usually the acute cases. So in your real exams like the PACES exam, the acute cases are not given. But keep in your mind the ventricular septal defect or ventricular septal rupture due to the myocardial infarctions is another important cause, my dear, causing the ventricular septal defect. In that case, that you need to do the bedside transthoracic echo, or if you can, the transesophageal echo to make the diagnosis, and the patient will have the hemodynamic compromise, and you need to operate immediately as early as possible in medical and cardiac emergencies to manage them surgically. So yes, the acute cases are not given, just keep in your mind the congenital cases are given in your exams, my dear. So examiner will ask you, in his case, like the residual VSD without any of the hemodynamic compromise, what will be the management? The management is to follow him. Follow-up will be the best management, and to prevent him some of the important complications future. The important complication is an endocarditis. It is said that he shouldn't go for any of the prophylaxis, but he has to monitor the endocarditis prophylaxis. So what will be the management of this young boy having the VSD, residual VSD, as you said, without any hemodynamic compromise? The answer will be, sir, I'd like to follow up this young boy to see clinically as well as the echocardiographic follow-up. If the patient develops any of the hemodynamic compromise as clinically evidenced by, then I'd like to see him, the clinically, especially any evidences of the pulmonary hypertension, and also any evidence of the apex V thrusting as well as the displaced, that will give us the idea the left ventricular dilated, and also evidence of the left heart failure, and also any reversal of the shunt as well. will give us the idea to go for the surgical corrections once again. And the surgical corrections can be done by the open heart surgery, and these surgical closure usually done by the pericardial patch or maybe the enlarger device. And here's a percutaneous enlarger device closure is a very promising way to close the ventricular septal defect, and it can be done. So examiner will ask you, what is the management of the ventricular septal defect? Yes, my dear doctor, the ventricular septal defect is a small VSD with no pulmonary hypertension, means the normal pulmonary arterial pressure, clinically as well as by the echocardiographic pictures. So just you need to monitor the patients and reassure the patients, and you need to just to once again just endocarditis prophylaxis that you need to do and encourage the patients to live normal lifestyle. So yes, my dear, means that the small VSD with normal pulmonary arterial pressure is a normal lifestyle just to monitor with endocarditis prophylaxis. In contrast, the large VSD with the pulmonary hypertension with or without right heart failure or maybe the left heart failure. So we need to manage all the features altogether. We need to manage the pulmonary hypertension. We need to manage the left ventricular failure. We need to manage the right heart failure. We need to give them and put this category of the patients on the endocarditis prophylaxis and prepare the patients for the VSD closure. Now, what are the indications of the VSD closure? Definitely the way that I have said, my dear, means that severe pulmonary hypertension, right heart failure, left heart failure, means the hemodynamic significant features are there. So yes, we should plan for the surgery. But one of the important talks, just keep in your mind and give the good impressions to examiners, my dear. What is that? Just tell them that pulmonary as well as the systemic arterial pressure gradient. If the examiner is asking, what will be the indications for going for the VSD closure? You will tell the large VSDs with the pulmonary hypertension, right heart failure, left ventricular dilatation, left heart failure. But the most important are the QP and QS ratio more than 2:1. And sometimes the examiner is asking, what are the contraindications for the VSD closure? The single answer, my dear, irreversible. I said, what is the word? Irreversible. Severe pulmonary arterial hypertension. So the single contraindication is the irreversible pulmonary arterial hypertension. We can't go for VSD closure. Sometimes the examiner is asking, is it something like that always the severe pulmonary hypertension is a contraindication? So how can he assess actually reversibility and irreversibility, as you said, for the contraindications for the VSD? The answer will be, my dear, the severe pulmonary hypertension with the reversible evidences. And the reversible evidence is done by the two important things. Number one is a vasodilator testing. If the good response to the vasodilator testing, then yes, we can go for the surgery. This is the reversibility of pulmonary arterial hypertension. The second one, the pulmonary arterial biopsy showed that the reversible changes. These two important things will allow us to go for the VSD closure. So the answer is VSD closure, yes, with the severe pulmonary arterial hypertension with the reversible or reversibility. And this reversibility means that the good response to the vasodilator testing and also the reversible changes in the pulmonary arterial biopsy findings. I hope that you enjoyed, my dear. Thank you very much. So this young boy having the X-ray done immediately after the operation. You see the wording is given here for the midline sternotomy, suturing, and this is the post-surgical X-ray. But beforehand, yes, it was the echocardiography. You can see the echocardiography shows the evidences of the VSD, and it's written here, VSD. So this is the VSD, and also you see that it is written echocardiographic findings are suggestive of ventricular septal defect membranous type with probable normal pulmonary arterial pressure. And this is also, this is the VSD PPG. The VSD velocity is taken here, the waveform. But yes, this is the before the surgery.